Hello and welcome to today's webinar, Rapid Antigen Testing, Improving Respiratory Disease Management in Urgent Care. I'm Samantha Burke, Administrative Director at NERUCA, and I'm so glad that you could join us today. Now, before we get started, just a few quick housekeeping items to help you make the most out of today's session. This webinar is being recorded, and following this session, you'll be able to access the recording on demand through Zoom and on our YouTube channel. Now we'll have time for Q&A at the end, so feel free to submit your questions at any point using the Q&A box at the bottom of the screen. Now for those who may be new to us, NERUCA is proud to be in its 12th year of serving the urgent care community across the Northeast. We work to strengthen and support urgent care medicine by providing grassroots representation at the local level, tackling legislative issues at the state level, integrating urgent care into broader public health initiatives, and delivering education and outreach to elevate the role of urgent care in the region. Now, we bring our mission to life through engaging programming, including today's webinar and our annual conference. We're so grateful to everyone who joined us last month at the NERUCA Annual Conference at Foxwoods Resort and Casino in Connecticut. It was an incredible few days of learning, collaboration, and connection. And believe it or not, we're already gearing up for next year's event, so stay tuned for more details. Now, lastly, I would like to thank our corporate sponsors for their continuing support. There's a little bit of a list: Aptitude, BioReference, Extion, Fresh Paint, HealthTrackRx, Metropolitan Healthcare Billing Services, Midmark Corporation, Pfizer, Solve, Medline, Healthium AI, and of course, a special thank you to today's sponsor, BD. We're pleased to be joined by Jennifer Gerard, Marketing Manager at BD, who will be moderating today's Q&A session. And with that, it is my distinct pleasure to introduce you to Dr. Rajesh Garia.
Thank you, Sam, for that great introduction, and good afternoon, everybody. Uh, so, uh, my name is Dr. Garia. I am a board-certified emergency physician and working in New Jersey, and I've been working full-time urgent care for the last 13 years in various settings, various practice settings. Currently, I work at CityMD, which is a large urgent care practice, over 130 offices within New Jersey and New York. And I am also a member of the board of directors of NERUCA. So I'm very happy to be here today to talk to you about a very important topic: rapid antigen testing, improving respiratory disease management in urgent care. So I'm going to start off with a few slides. I'm assuming a lot of the participants today are from the Northeast. If you're not, well, welcome anyway. But the Northeast has some unique qualities that make this topic even more important. Um, we're currently kind of getting into flu season here in the Northeast. Um, we have the most densely populated metropolitan areas in the country, and this creates higher patient volumes. We're seeing during the peak flu season on average of 80 to 120 patients per day at our sites. So we're often seeing co-transmission of these viruses: flu, RSV, COVID. Because of the high patient density, these things, there's higher transmission of these respiratory illness. People are cramped together, waiting rooms are packed. And so this creates a public health crisis as well. Primary care offices are still not routinely testing. You'd be surprised. I see a lot of patients coming in and just common respiratory complaints, and went to their primary, and their primary provider said, "Well, we don't do testing here. Go to the urgent care." It's almost like we were rewind to back in the Omicron days of COVID, like in the heat of it all, where primary care was definitely not playing a role. We played a huge role, but it seems like the primary care offices have not caught up with this, and they're not offering this testing. So that leads to even more visits to urgent care. So it's very important to have efficient workflows. That's going to be critical to manage this high throughput. So as I said, we have a high population density. We have long, very cold winters, And that leads to a lot of this co-transmission of these viruses. That's very unique to our region of the country. We have a care-seeking culture, and I think this is an important thing here, where patients in the Northeast tend to be highly engaged with healthcare consumers, and that can be a good or bad thing. It's good to know, and be up on your healthcare and be involved, but at the same time, they're also on Google a lot. They're doing a lot of research. They're well read. And so when they come to see you, they have expectations already and they are expecting answers. Okay. And so that kind of, I'll elaborate on that later in the presentation, but that care seeking culture, I think, is very unique to this sector of the country. So these high volume surges, create a lot of staffing pressures, not to mention the call outs for the staff sick and everything. So it becomes very important to kind of be very efficient despite these challenges and staffing pressures. Um, and then we have the demographic diversity in the Northeast, where we have a lot of patients that can't afford healthcare, and they tend to end up in the urgent care as well. So all of this leads to big public health and regulatory issues. And so the quicker we can give patients answers, we can kind of make the public aware of what's going on, and not and contain viruses, and that's going to be important. Like you saw in COVID, where we had to, have direct patients and educate patients on what to do at home so they don't spread these viruses. So we're going to start off with some cases here, and I think this is a good way to kind of drive home some of these points I want to make today. So we'll start off with a 38-year-old mother who brings her 6-year-old into urgent care during the peak of COVID. So we're kind of rewinding here. And the child had sore throat, fever, mild cough for 2 days. So you can see the vitals there. Temperature, so she's got a low-grade fever there, a little tachycardic. Otherwise looks okay as far as the vitals are concerned. She's got some mild erythema of the throat, clear lungs, non-toxic looking. And the waiting room is full. She's visibly, the mother is very anxious. And she's concerned about strep, concerned about flu, COVID, obviously. It's the middle of the pandemic. And she wants clarity before sending the child back to school. And, you know, that means on the spot information, right? Not like, okay, well, I think it's this, it may be this. Why don't we try this? And well, we'll keep your kid out of school just in case. Those are sort of just kind of guessing. And so we want to kind of, the goal is to give them as accurate an answer as possible on the spot, or at least within a few minutes, so that she can make decisions about what to do with her child, and we can get the right treatment going. Next case is a 24-year-old patient presents with a fever, severe razor blade throat pain, denies any cough, runny nose, difficulty swallowing. Also low-grade fever, a little tachycardic. Throat is very red, no exudates, no cervical lymphadenopathy. So in New York City specifically, we've been seeing an uptick in this COVID variant, the Nimbus variant, and I'm sure many of you are aware of that. And it has this characteristic razor blade throat pain. And so that is very important because there's a lot of overlap there, um, with the upper respiratory symptoms of COVID and then strep as well. So it was recently identified as a variant in New York City, has those common symptoms and overlap, mimics strep throat or viral pharyngitis. And so rapid testing, again, is going to be essential to distinguish between, is this COVID-19 or is this really strep? And so that's going to influence our diagnostic decisions, isolation decisions. Are we starting antibiotics, or should we actually be doing antivirals on this patient? So we always have to now think about that, especially in this region when patients are coming in with sore throat. Should we be doing a rapid strep only, or should we be considering COVID? And I think, you know, each year COVID is mutating and presenting with different symptoms. It used to be back in the Omicron days, it was loss of taste, right? Um, we're not really seeing that anymore. We're seeing, slightly different clinical presentations. And now we have, this variant with the sore throat. It's not that we're testing for the variants, but we should be aware of the different types of symptoms here. And case 3, the dad brings a 3-month-old male in with fever and cough, got a past medical history of prematurity and chronic lung disease. So right off the bat, my spider senses are kind of, alerted here. And, there's a heart rate of 138, tachypnea 42, low grade temperature, 95% sat, so not too bad there. And the child does not look toxic. There's some mild retractions there, no nasal flaring, lungs are cleared, auscultation. So, you know, this is definitely something, a case where I'd be very, I'd be careful here. This is the kid that has some comorbidities, prematurity, chronic lung disease. And in order for me to advise these parents, I mean, obviously I'd want to know COVID, flu, but RSV is a real factor here and really should be considered. Um, and frankly, if I knew that this patient had RSV, I'd be more likely to send this patient to the ER, because they're going to need, monitoring, and, going to need to be a little bit aggressive as far as, making sure they don't decompensate, as opposed to doing some shared decision making, saying, well, it could be RSV, we'll send out a test, and child doesn't look too bad right now. It's viral, quote unquote viral, and you can go home and just kind of wait and see, and then we'll call you, we'll send out an RSV, and we'll let you know in about 48 hours. Well, who knows what's going to happen in that 48 hours, right? So this would be a case where I'd be really, for even for not as much the treatment, because they're really going to change my treatment in the urgent care, but it's really going to affect my triage of the patient and decision making. So if I could have a rapid test that gives me that answer within a few minutes, that would be very helpful. And so RSV, is the leading cause of hospitalization in infants under 1 year of age in the US. Approximately 58,000 hospitalizations annually for children under 5, 300 deaths annually in this age group. And so early detection in those high-risk infants prevents deterioration and reduces the ER burden. So overall, just putting respiratory illnesses in context, it's a big deal, and this is like very timely for this presentation. I mean, flu causes 9 million illnesses and 10,000 hospitalizations annually in the US. RSV, like I mentioned. And the key here is the co-infection risk during peak season. We're seeing a lot of these things. Just the other day, I had a COVID and flu positive on the same patient. So we're seeing a lot of co-infection. So getting that accurate diagnosis supports timely triage, and then, it's a public health impact as well in terms of vaccines or isolation, return to work or school. So we want to be confident. That's the bottom line. And so, like I mentioned, the clinical symptoms, there's a lot of shared symptoms overlap. So fever, congestion, cough, sore throat are the main symptoms of many of these illnesses. But remember, allergies, it's not just a spring thing. You can have seasonal allergies all year long, winter allergies. And so a lot of those allergy symptoms like postnasal drip, congestion, these things, even sore throat, have overlap with strep and these common viruses that we see. So it's very important to be able to differentiate that and guide diagnosis. And if you can deliver that information accurately, it establishes the trust between the patient and the provider. And I'll go into how important that is as we move forward. So the ideal workflow in urgent care, and I'm going to go over what we do in our workflow, is the MA will go in and swab the patient if they fit certain criteria. So in other words, if the patient has a fever and any viral symptoms, the MA is going to recommend or offer testing. Obviously, if the patient refuses, we don't do it. But the MA is going to say, this sounds like we need to test you. And the patients rarely question that, at least in the Northeast, because they're sort of there for that anyway. And they know that they want to know, they have that, as I mentioned, they're well read. They want to know exactly what to do. So the MA is going to do the swab, and that's going to be done before I even enter the room. All right. So when I walk in the room, I can examine I already have the vital signs. I can examine the patient and I have the tests results ready to go. So that's gonna, create this it's a team-based workflow, and it's gonna help me be able to make decisions on the spot. And this is critical when you have a waiting room full and you're seeing upwards of 100 patients a day. That's 5 to 6, sometimes 7 patients an hour. Um, Having this type of workflow helps you really increase your throughput time and be more accurate as well. So that's a huge win. You want to have as many of these patients pulled out of the waiting room and fill these rooms up as fast as possible. So revenue generation with point of care testing, it's nice to have everything in house. So you're keeping the revenue within the clinic. You're not relying on external labs like Quest or LabCorp. Um, Improve return on investment on testing equipment and staff training, because these tests do not really they don't require a lot of staff training. They're payer reimbursed because they're CLIA waived, so they're not. This is like a point of care glucose test, right? It's not. There's not a lot of sophisticated infrastructure or training that needs to be done, and you can bundle tests. So you can do flu and COVID on one cartridge, as long as you're documenting the medical necessity for that. It does increase the per visit value by test bundling. And of course, public health, right? It's a, immediate diagnosis. We can kind of educate the patients, reduce spread. God forbid we get another pandemic. This is going to be very important. So we can advise patients appropriately about return to work, return to school, support public health messaging, virus transmission, and empowers patients to act responsibly. So it's very easy to use, low training barriers. We're talking about clear wave tests, minimal training, easy to follow workflows and results interpretation. Um, there's no daily calibration of these testing devices, and it's very compatible with busy environments. Um, So why BD Veritor, the Plus system? I mean, the single platform system supports multiple high yield assays. Okay, so the tests are going to include COVID-19, flu A, B, RSV, and group A strep. And so you don't need multiple devices. You're going to you'll be able to have one cartridge that's going to give you this, whether or not we routinely use the COVID and the flu on one cartridge assay, because that's the majority of our testing. Um, and you can get reliable results within minutes. So the testing devices are very small, and they can be used basically, and you can keep them in one central location in the lab, or you can bring them room to room. They don't require a sophisticated setup or a wall plug-in. They're very portable, which makes it really nice. And not having that infrastructure that's huge. So we usually have about 3 to 4 of these testing devices per site. We have 2 workflow modes. Okay, so we have an analyze now mode and a walk away mode. And so with analyze now, you can accommodate batch testing when manually tracking development time. So you can insert the cartridge, and it's going to give you, after you wait that 10 minutes, you can insert this cartridge, and it's going to give you a result. Walk away is inserting the cartridge. You can walk away, see more patients, come back, and then you'll get the result. So it really depends on your workflow and your volume. Um, we tend to have everything set up in a back area in the lab, and we have multiple cartridges lined up with the patient's room number and the patient's initials or name. And we set timers. When the timer rings 10 minutes, we'll put that cartridge in, and we'll get the result right away. So we're not tying up the machine right off, while with one cartridge. So it just whatever works with your workflow. Okay, so that's what works for us. So you're not going to get, by having that digital reading, you're not going to have to, you're not going to have a visual interpretation. Digital results are displayed within 3 seconds of the cartridge insertion, and that's going to reduce user error and missed faint positives. And that gives you consistency across different providers and different shifts. There's been multiple studies that have shown that, compare digital interpretation versus the human eye and enhancing accuracy with rapid testing. And the bottom line is that your human interpretation is vulnerable to error, especially with faint positives. You're kind of have to deal with the lighting conditions, fatigue, inexperience with the staff. So BD Veritor Plus delivers digital objective results in under 3 seconds. So you're going to reduce your false negatives and improves confidence in decision making. I mean, there's many times when I'm looking at a strep and it's this very faint line, and or even a COVID or flu test, depending on when the patient presented, it could be very faint, and you're kind of passing it around. Hey, do you see a line here? Do you see a line? So it's like having that digital reading, whether it's plus or negative, is huge. So the entire system can be integrated with your EMR, and that's an option, but it gives you connectivity and it enables automatic test result documentation and reduces charting time for providers. So anything that can reduce clicks or any extra steps is huge for the workflow. So having this automatically kind of get integrated into your EMR is huge. So if we rewind and we think back to the COVID-19 pandemic, I know it gives us all like nightmares and everything, but just, the way it started was PCR testing really, early in the pandemic. And initially only PCR tests were available and authorized. And the thing with that was the providers were doing those. The MAs, the provider had to do it. I remember when we first started, we had patients coming in and it was like a drive-through. We can only do a certain number a day. And I was like, you know, just sticking my head out the drive-through window and doing a PCR. And because I had to do that, I had to do all the PPE and everything. I had to, don the PE and put it away, throw it away and then do it again, all over again with the next patient. So it was a very time-consuming process, you know, doing the PCRs. Um, and just an extended patient visit, really. And then, of course, the labs, right? So the lab turnaround times range from 24 to 72 hours. And this created all kinds of problems, samples not being reported back in time, the staff that you need to actually call back all the patients with those results. Who's calling the patients, right? If they leave the clinic, we need to dedicate someone in our staff to call those patients the next day and say, hey, you're negative or you're positive. So samples were lost, labs were overwhelmed. And so it just really wasn't an optimal uh, situation. And as everything evolved, as that testing demand grew, patients just really became frustrated. They expected quick answers. We needed to get patients, give them the right advice as whether, can they return to school? Can they go back to family? So really rapid antigen tests became a little bit more common. They enabled diagnosis in minutes, not days, and they allowed testing to be delegated to MAs in most urgent care settings, which was huge. So we had, our MAs and our scribes doing the testing. So it reduced provider workload and PPE usage. So rapid antigen testing is going to give fast results, low cost, and very easily accessible and easy to interpret. PCR testing gives you that high sensitivity. It's used more in a confirmatory role and really requires a sophisticated lab infrastructure. So today's reality, rapid testing is really the new norm. I mean, the viral evolution and the widespread exposure reduces the need for that confirmatory PCR. Rapid testing now supports most clinical decisions, and it's going to guide us, in terms of, antibiotic stewardship. Do these patients really need antibiotics, or maybe they do need an antiviral, or maybe they need none of that? Why start the patient on an antibiotic pending testing that you're doing, some of these molecular tests. So they're going to come back, even if it's the next day, the patient is going to say, well, should I start this antibiotic? Should I not? Should I hold it? They don't want to wait. And you also don't want to start them on something unnecessarily. So, antibiotic stewardship is a very hot topic now. Even payers are aligned with that. And so anything the payers, are in tune about, we should probably be, doing. Not to say it's all about getting paid, but it's really just the best clinical practice. PCR is still selectively used, if you have these high risk immunocompromised patients, atypical cases, or maybe a patient came in like 1 hour after their symptoms started, and we're not going to rely too heavily on a rapid test. I'll send a PCR. But it's pretty few and far between there. I'm really not utilizing PCR as much in our practice at this point. Also, employers and schools aren't really expecting PCR testing as well. So rapid testing just gives us that ability to, get a same day diagnosis, treatment, and disposition, not same day, but even within a few minutes. And that brings me to this post-COVID patient expectation. And I think we're really dealing with a different type of patient now post-COVID. Not that COVID is over, but when I say post-COVID, I mean post that pandemic. And these patients are no longer satisfied, with a vague diagnosis like virus or cold. They expect providers to rule out serious and contagious illness, those being COVID, flu, and strep. And they want clarity. They want some specific instructions. They're taking time out of their day to bring their child to an urgent care, and they want to know, do they need to stay out of school? Can they go right back to school today? Do they have to wait 3 days and then go back to school? Like, what's the deal? And so they expect that from us. And patient satisfaction is directly linked to diagnostic confidence. And dissatisfaction leads to lower return rates and negative reviews. And we see this time and time again. I mean, you know, um, I find that patients are a lot more, you know, trigger happy. Before the COVID pandemic, I was trying to explain to patients, well, it's just a virus. We'll do some supportive care, and if it gets worse, just come back in. And now these patients are just, a lot of them are not happy with that. They at least want to rule out COVID. Doesn't matter if COVID mutated, 20 times and it's now behaving like a minor, respiratory illness, upper respiratory illness. They still, want to know it's not COVID, it's not flu. It has that bad stigma to this day. Um, and so, when we look at the NRC health survey in 23, 84% of urgent care patients wanted a definitive diagnosis at the time of the visit. So clinics using the rapid testing scored 18% higher in patient satisfaction surveys. Their repeat visit likelihood, increased when they received test-based explanations on the spot. And lower scores were seen when testing was deferred or not offered. And, this applies to even the next day, and maybe it's more in the Northeast. I mean, but, in the Northeast, if I can't imagine telling the patient, we'll call you tomorrow and let you know if you have COVID. I just can't imagine it. And I've been doing this full time now for 12 years. And I just think that not only is that going to be an issue with our staffing, and our manpower dedicated to trying to call all these patients back, because, so the say result comes back tomorrow. Um, my MA is going to try to coach that patient, as far as what they need to do with that result. The provider is no longer working. They went home. So, how is that patient going to be coached? What treatment is going to be started? So you're going to have, maybe even a provider, be doing all those callbacks, and it's just, I just couldn't imagine it fitting with the workflow in 2025. So, we go through surveys, and these are some of the things that we see. I just wanted to know what I had before going back to work. The test came back negative, but it gave me peace of mind. They told me it was just a virus. It felt like a guess. I didn't go back. The doctor explained everything after the strep test. I appreciated that. And when they didn't test, I felt like they weren't being thorough. And these are just real things that patients say, and we see it over and over again with the reviews. So in summary, rapid testing with BD Veritor Plus, simple, portable, easy to use. It really streamlines the operations and supports revenue retention, enhances the accuracy, patient satisfaction, and most importantly, provides stewardship, really fine-tuning your treatment, whether it's antibiotics, antivirals, or just advising them just to do supportive care, um, and getting timely intervention started, whether that's treating the patient from the urgent care or actually triaging them to a higher level of care, which may be the ER. So I want to thank you all for joining us on this webinar. Very important topic, and I'm always open for questions. We have some time now for questions.
Thank you, Dr. Garia, for that great presentation. So we do have a few questions. And again, just everyone, if you have any questions, please put it into the chat at this time. One question was, do rapid antigen tests reliably detect novel variants of the COVID virus?
Yeah, so that's a great question. And the answer is no. At this time, they do not. And patients actually ask us this a lot. And the response I give them is that, while it may be nice to know the variant, it's not going to change our management. So at this point, and which is true, right? For the most part, it's more us being aware of the different symptoms of these different variants so that we can make a decision whether or not to test for COVID or not. But most of these variants aren't going to change our clinical practice. So we're not going to advise that we test for that. Even during the height of the pandemic, we weren't sending these things out for variant identification, whether it was Omicron or something else. So no, not at this time.
Okay. Could you share any immediate thoughts or projections you have about the upcoming 2025-26 US respiratory season? And what can or should healthcare providers be doing to better be prepared?
Well, I think it's, at least in the Northeast, I think it's going to be the same. And, we're going to see a huge uh, triple threat with flu. I want to say double threat, mostly flu. We're still going to see COVID. And I think now with these new variants, with presenting with the sore throat, we're going to have to really think about when we're thinking about strep, we still going to have to think about COVID because of that new variant symptom presentation. And if you remember last year, there was a huge boost of RSV as well, especially in pediatrics and the elderly. So I can see that coming back. That was a huge thing in the media as well. So we had many patients coming in asking for RSV testing. And so we actually had to start sending those patients, doing viral panels and sending them out, which would take about 48 hours. So now, if that recirculates, which I think it will, because a lot of these things co-circulate, having the rapid test to really be able to help the patients know if they have RSV or not, especially in pediatrics, would be huge. So yeah, I could see all three just making, doing the same as last year, and we need to be prepared for that by being able to test those people on the spot.
Okay, great, thank you. Another question, in your community, are patients requesting specific tests, and how do you respond?
Yes, they absolutely do. They will come in and they will still say, I just got off the plane. I was away in Mexico. I'm going to see my grandkids tomorrow, babysitting. I just want to make sure I don't have COVID, and they're totally asymptomatic. So we're still seeing that, several years later, and they are requesting flu. They're requesting COVID. Um, And also if they're coming in with upper respiratory symptoms and they have a fever or they have any of these viral symptoms, they are not, like I said, the workflows usually automatically test them for COVID and flu, and the MA will make them aware that we're testing. And most of the by the large the majority of patients do not decline the test, because they want to know. I mean, they're still kind of wired that way, that they want to know, at least I don't have COVID and flu. So yes, they do come in and ask for these things. They ask for strep tests, they ask for those things. So as I said, that we have in the Northeast, especially, these patients are very engaged with their care. And before they even come in, they've already kind of researched what they want. So
Yeah, and touching upon that, have you noticed differences in patient trust and satisfaction when using rapid testing versus clinical judgment alone?
absolutely. There's no doubt about it. If I could, tell the patients, you know, you have, you know, I make it part of my spiel. I said, you know what, you have these symptoms, but thank God you don't have COVID. And it's like I'm so happy we were able to rule that out. And now we can just say you have this virus. And there's a lot of viruses out there that can cause these symptoms, but at least we know you don't have COVID. And we just kind of, and that's the approach I have. We're using the test, we're ruling out the ones, because if you had COVID, maybe I'd start an antiviral on you. If you had the flu, I'd probably give you a Tamiflu. But now that I know you don't have those two, we can sort of put you in this collection of viruses, and I can say, well, supportive treatment, supportive care. So yeah, they really, and I could tell by their interactions, their facial expressions. I've been doing this for a long time. I could tell by their mannerisms when they leave the room. It's like, thank you so much. I really, I'm happy I came in. At least I have some answers, and I know I can go visit my family. I can go hop on a plane tomorrow, and you could just tell, and it's after we've been doing this for a while, you could read patients really well. And I think that I can't imagine not having these tools at my disposal, because I would be leaving patients just like kind of ambiguously, like saying you have this virus. And, if I sent out a test, oh, well, I'll call you. Somebody's going to call you in a day or two. It's just kind of open ended. It doesn't really give them closure. And so I would feel uncomfortable with that. And I know the patient would feel uncomfortable.
Um, we have a question, how is the test performed? So if it has like similar workflows, if you could just kind of give a high level overview.
Yeah, so the test is a nasal swab, and you're basically um, just going into the nostril, just like swabbing, in a circular motion near the uh, you know, tip of the nair there in the nostril. You're not doing a nasopharyngeal like a PCR, so you're not really going posterior at all. It's just a, anterior nostril there. And once you collect the swab, you know, we basically put it in the reagent, and put it into the kit, uh, and then you're putting it onto the cartridge. Sorry, yeah, you're putting that into the cartridge, adding the reagent, and then you're just going to wait 10 minutes. And then what we typically do is, let's say the MA goes in the room, collects the swab, sets up the cartridge, puts it in the back. We have that lab area. They put the cartridge there on like a chuck and label it, and then they go triage the next patient, bring the next patient in. Okay. Meanwhile, I'm seeing that patient already while this test is already cooking. And I might even have the result by the time I, go in to see that patient. The scribe or the MA is already seeing the next one. I'm bringing that test that they already did into the room, and, coaching the patient, treating the patient, and dispositioning the patient. So that's how it works. Um, and we're not doing that on every single patient, but patients come in, fever, upper respiratory symptoms, that test is being done, it's being put into the back. Once that timer rings, either myself or somebody else, another scribe will put that into the device kit, into the machine. You'll get that digital reading, and then you can go disposition the patient. So that's really how it works. You
Okay, and
can
then
bring that, we can bring those machines into the rooms too. So a lot of times, I'll have depending on how busy we are, I'll just tell the scribe or the MA to leave the test in the room and the machine, which is so portable. Like you can just carry it into the rooms. And so I'll just come in the room, and while I'm talking to the patient, and when I'm done, I can easily run the test in the room right there and say, well, here's your result. And so it's the workflow would be, I would feel very uncomfortable, especially this time of year, going in the room, taking my history, doing my physical, and then saying, well, let's test you now. And then testing them, going out of the room, waiting, and then going back in the room. That would just create a complete backflow, or it would just totally disrupt our workflow. By doing this, I can see easily 5 to 6 patients per hour. So
excellent. Another question specifically, right? Because you touched upon RSV. Since RSV currently has limited therapeutic options available, what are the benefits to testing for it?
So the benefits, that's a great question. And you're right, there's minimal clinical, it's like, I'm not going to do, in the urgent care, if I find out you have RSV, I'm not going to treat you with anything really. But it's more of a triage utility, right? In that patient, the infant that comes in, you know, and they're kind of 50-50 whether you would send them to the ER or not. And it's more like, okay, now I know you have RSV, I'm more inclined to send you to the hospital, and giving that, getting them to that higher level of care so they could be observed, because you have an infant here with, like, prematurity and lung disease and these kind of things, but their vitals look okay. But having that additional information like RSV, that's going to help me. Same with the elderly. And on top of that, it's more the public awareness of RSV. So let's say RSV makes a comeback this winter, and the media again blasts it out. Well, now I'm going to get all kinds of parents coming in asking for RSV, like last year. And so they're not going to be satisfied with, well, you know, let's do an RSV viral panel, send it out. Most of them are going to they're going to appreciate if you can tell them right there, then and there. But yes, but from a clinical standpoint, I'm not going to do a single thing differently if treating you, if I know you have RSV. That's why when a 25-year-old comes in healthy with upper respiratory symptoms and they ask for RSV, I just take a step back and I'm like, you know, we could
Mhm.
do it. Yeah, we could do it. I mean, this patient clearly has been Googling and watching the news, and we could do it, but it's not going to make much impact here at all. So sometimes I'll advise them against it, in that case. So mainly in peds and the elderly.
Okay. Do you ever worry about false negative rapid antigen tests due to visual interpretation, user error?
Yes. Absolutely. It's a real thing, Again, it depends on lighting. It depends on, are you on your 100th patients and your contacts are blurry now, and it's like, I've been there, right? You have the whole element of color blindness where, there's a certain percent of the population that's colorblind and can't see these faint lines, especially early on. And so, having that digital readout is huge with that, trying to eliminate that. And it happens all the time, uh, you know, I've had MAs like, can you just like double check this? Well, we're not sure, and it's like, you know, let's just do it all digital and like have the readout there so we're accurate. So
Excellent. What are some best practices for interpreting rapid testing workflows without disrupting patient flow during those high volume days?
yeah, I think that just goes right back to what I was saying before about our workflow. It's trying to, you know, anticipate what tests are going to be needed for this particular patient, before the provider walks in. So the patient's triaged, you see there's a fever, there's some respiratory symptoms. Having the team initiate testing, rapid testing early, and letting that cook before the provider comes in, that's huge, because the provider can walk in, they already have that objective information that will help them make a clinical decision, and so that patient can be dispositioned faster, and you can open up the room and bring another patient in. And like I said, you can bring those machines from room to room. So whatever works for you, right? You can have the machine in the room, you can have the machine in a lab area, and then, have the test result, run, and then you just bring that information to the patient in the room while the MA is already in another room triaging someone else. And so that's I think the ideal workflow. And I think it creates it makes you more efficient. It's higher throughput. And it's also better patient care and higher quality care, as well as, increasing patient satisfaction, because they're, number one, they're not waiting. I mean, our waiting rooms are, even on the busiest day in our waiting rooms, they look empty. So the patients come in flu season, and there may be one patient sitting there in the waiting room. And they're like, wow, this is great. And why is that? Because every room is full. So that's the high turnaround, because we're able to get patients in and out. The patients always come in and they're like, wow, this place is quiet, it's clean, there's no one here. I'm going to I would love to just, I don't mind, no one's here. And in reality, we're busy, but patients are in and out, right? So yeah, that's the way you want to do this. And I think that works the best.
Yeah. This is an interesting one that came in. How can urgent care clinicians leverage rapid testing results to educate patients about vaccinations and preventative behaviors?
Well, yeah, I mean, that's a good question. I think, if they're coming in and they test positive for the flu, or they test positive for COVID, um, you can advise them on, if they've never been vaccinated, you can, tell them maybe you should consider vaccination. Not that it's going to prevent getting those viruses, because I've seen many patients that have been vaccinated come in and still get those viruses, right? But maybe the severity would be less likely to end up in the hospital, so, um, that's definitely information I can give patients, especially if we see trends that keep coming in and they're testing positive. Maybe they need to go see their primary care doctor to get some immune system workups, or to see if they're having any reason they may be prone to be getting these infections over and over again. But yes, and public health, yeah. I mean, if I have a COVID patient, I would, be more inclined to give them a few days off from work. Not that we still have isolation guidelines and quarantine guidelines, but I'd be more inclined to give a COVID positive patient a couple days off from work, more than I would maybe a strep patient, or a flu, or just a viral symptom patient. So yes, it does inform from a public health perspective. A lot of these patients want school notes, they want work notes. So having that information helps me advise them on that. And I can advise them on vaccines as well.
Another question that came in, as urgent care centers increasingly serve as a community's front door for respiratory illness, what strategies do you recommend for integrating rapid test data into public health reporting and surveillance efforts?
Yeah, so I think that's important, especially, just learning, you know, just reflecting back on COVID, is that, the nice thing about this is that we could incorporate all this rapid testing, um, that we're doing at our clinics into the EMR. And so when you have that interface into the EMR, you can easily do a query on spikes, and, time of year spikes and what we're seeing. And, we were, during the pandemic, CityMD, I mean, we were like an epicenter for testing, and the New York City was really, really relying on our data to drive recommendations and public health recommendations, as far as, advising patients on, a quarantine and containing the spread and all this. And so they were just relying on the data we provided. So it's nice to have that interface. And I think that makes it possible to collect the data and influence public health.
Another question, from an operational standpoint, what metrics or KPIs do you recommend, if any, urgent care operators track to demonstrate the value of point-of-care testing, both clinically and financially?
That's a great question. I think I would track return visits, because I am finding that a lot of the patients that we do the rapid testing on and they feel like they got an answer, they got the right treatment, they are more likely to return because they feel trust in the providers, giving them the appropriate information. They didn't have to wait that long, right? There was no hiccups in the process. Where we see the problem is that the patients get tested. We say, well, you have this virus, we'll call you in a day. Even if it's a day, there's a fragment there. There's a disruption. And, they may not get the call. There may be some issues and it's just less smooth of a workflow. And that's where we see patients get frustrated. They write reviews. Well, I never heard from anybody. They told me they would call. They never did. I wasn't made aware of what I'm supposed to do once I have this result. So there, though, I would track return visits. I would track patient satisfaction and NPS scores. We routinely track that per quarter, NPS scores, and just take a look at what patients are saying in there, and how much do they value and appreciate the testing, and try to make a decision based on that. So I think and then reimbursement, right? Being able to bundle the tests together, the COVID and flu on one cartridge, and then making the medical necessity for that and documenting that and seeing your reimbursement rates for these things. I think you'd be pretty surprised and happy with that.
This is a very popular topic, so I think we have time for one more question. You did mention that rapid testing can be initiated by MAs before provider evaluation. What have you found to be the most effective workflow model for maintaining both speed and diagnostic accuracy during those high volume winter shifts?
Yeah, that is a popular question. I mean, I think that's just to reiterate. I mean, it's really giving me as a provider the information I need before I set foot in the room. Like that's the key, right? So the patient is triaged, everything is set to go, it's all teed up for me. I can go in and immediately tell the patient they don't have COVID and flu for those respiratory symptoms, but here's what we're going to provide you. Or yes, you do have COVID, you do have flu, and we're going to give you either an antiviral or an antibiotic, whatever it may be, and just dispositioning the patient, and then filling the room again and doing the same thing over and over again. By doing that, I think that's the best way to improve your workflow, is just having the ability to get as much of these data points as possible before I can walk in the room. There are patients, I don't want to just say we test every single person. There are patients that refuse the test. Okay. That they come in with 1 week of symptoms. And let's say the MA says, well, we could do a test, no, I don't want the test. Or patients will come in with 24 hours of symptoms and they actually have real viral symptoms. Like, no, I don't want this test. But we don't do it. Give them the option. But as I said, by and large, most patients during this time of year will want the test. So.
Amazing. Well, I think that's just about all the time we have for questions today. And now, if we didn't get to yours or if something comes to mind later, please don't hesitate to reach out to us at admin@neruca.org. We're always happy to continue the conversation. So I'm happy to go ahead and close us out today. To Dr. Garia and Jennifer, during today's presentation, thank you so much for partnering with us on such an important topic in urgent care medicine. It's been an absolute pleasure learning from you today. And to all of our attendees, thank you for your time and attention during today's webinar. We had a very engaging Q&A session, so thank you so much for that. And we hope that you found this session insightful and valuable. A friendly reminder that the recording from today's webinar will be available on our YouTube channel and on our website in the coming days. Now, we really appreciate your participation, and we look forward to seeing you at our next session. Have a great day.
Thank you.
See ya.